Good afternoon, everybody. So this afternoon, I will be talking about osteoporosis, which is a topic that's very close to my heart, and we'll tell a bit what is it and how to look out for it and what are some of the complications from osteoporosis. Of interest actually is that next week on the 20th of October, we have World Osteoporosis Day. I'm very grateful for actually this opportunity so that we can be able to highlight the importance of this topic and the relevance to a lot of us and what impact it's got, okay? So we know that osteoporosis is a systemic skeletal disease that is characterized by low bone mass, and you get macroarchitectural deterioration. And this results in the actual bone being fragile and the susceptibility to fracture, which is where the problem comes. So you will then result in fragility fractures, which are also known as low impact fractures or osteoporotic fractures. So these terms are quite interchangeable. And what that means is mainly when you sustain a fracture that occurs from a standing height and less. And the most common fractures are hip, vertebra, distal, and humerus. And you'll see a lot of times the hip and the vertebra being mentioned quite a lot because of the impact they've got on the patient as well. I mean, is this really a problem? Is it something that we need to concern ourselves about? Yes, it is a problem, especially in patients over the age of 50. You can see the prevalence in the age 50 to 59 is about 10%, increasing up to more than 70% in the older population. And we know very well with the current technology and advances we have in medicine that our projections for a much larger older population is increasing. And same with South Africa. I mean, with HIV that came in, threatened the average lifespan with ARVs and all these therapies available. We all are living longer, okay? And these are kind of problems that we will have to deal with and we need to be aware of. Okay. So is it something that's a bit of a European problem, or do we have an issue in South Africa as well? We do have a problem in South Africa as well, with an estimated prevalence of about 40%. You would note in the slide that the prevalence was estimated from really 3 articles, which really shows to us how this is an ignored problem in South Africa and in the rest of Africa as well, because of this old mentality of that Africans have stronger bones and there's no problem of osteoporosis and there's no risk for fractures in Africans, which is not true as well. And what we know from data in Africa, you will see a lot of times when we're trying to estimate the prevalence of bone pathology in the country, we will either looking at specifically osteopenia or osteoporosis, and specifically looking at hip fractures, which are some of the most common presentations. In that, if you look at South Africa at the bottom there, you will see that it is not quite a rare. Obviously, it's a bit lower in black men, but if you compare women, African women are as affected as the rest of the continent as well. And we know as well that as much as we're missing data in our osteopenic patients and how many patients we've got with osteoporosis, a lot of the patients that sustain fractures are actually not sustained fractures in what will typically be classified as osteoporosis, but more on the osteopenic range. Why do you concern ourselves about bones? Is because when you sustain fractures, it's quite a big impact on your health, okay? It impacts mobility, independence. There's cost and mortality as well associated with it. Looking at data, looking at mortality post-hip fractures in developed countries, we know very well 30-day mortality has been reduced to an estimated around 6% mortality in the acute setting. And this is purely as a result of multiple interventions that have been put overseas to reduce mortality in terms of making sure this patients who sustain hip fractures end up in specialized unit with people who know how to manage also increasing shortening the time to surgery, which has an impact in the long-term outcome, and the importance of a multidisciplinary team as well. But the 1-year mortality of a patient who's had a hip fractures remains high at approximately 30% still in patients post-hip fractures. This is something I wanted to just think about it a bit more. Basically, any patient that sustains a hip fracture, 1 in 3 of those patients will die within a year. Okay, so this is not something that we can purely ignore and think of it as benign. It is an important event that has long-term outcomes. And when we look at South African data, we've got some data on hip fractures and mortality in South Africa, in that it's our short-term mortality is higher than in the developed countries. And obviously we would know very well it is purely because of our concerns with issues. The data comes from state facilities. It might be a bit different in the private sector, because a big impact of these is how patients' pre-morbid status is, how they are optimized for surgery, and how soon the surgery also happens, and all the other factors around that. And we know that's quite a big issue in the state in terms of delay and availability of theatre time for this patient to be operated. And our mortality is much higher, 2 to 3-fold higher than the one that's reported in the developed countries. So I'm not sure how many of us are willing to take a chance. Basically, what I'm saying to you, if you have a hip fracture, potentially within the month of that hip fracture, you're going to die. It's quite a big number. And if you don't die that month, in a year, your risk is still high for death. So it is a big problem. Not just that, we don't have any economic data from South Africa. It should be available the next couple of months, as there is quite a lot of work now being done with the awareness that we need to really take a look at bones in sub-Saharan Africa. But the total cost of fractures per patient is quite high. You can see more higher in the hip and the vertebra, and the humerus, which is often ignored. I don't know any of you are aware of any previous referrals for a patient for osteoporosis post the humerus fracture. It's not something that happens quite often. The hip, because it's quite significant, often people would think about osteoporosis, but in the other fractures, it is often ignored. And obviously with the vertebral, it's quite a big issue, because a lot of the vertebral fractures are often missed as patients are walking around asymptomatic and not detected. Just to give you an estimate, these costs are quite similar to costs that you would require in managing a patient with a myocardial infarction. It's quite in the similar range. So it's quite an important thing to think about. So it's not just the mortality in the short term and the cost, but what even scares me the most is the risk of subsequent fractures, because this is something I think we can do the most about, is that if you put in an intervention, is to try and prevent this from happening. That we know very well your risk of imminent fracture post an index fracture is estimated at about 11.58%. And more than 50% of the patients that refracture will refracture in the first 2 years after that initial fracture. And obviously having a second fracture would result in a higher mortality. And we know very well osteoporosis therapy improves your bone mineral density, not just the density of the bone, but actually reduces your risk for fractures. So this is a point where it needs to be important for us to make an intervention to try and improve outcomes in patients. In terms of the actual criteria and how osteoporosis is classified, we generally use the WHO criteria, which classifies normal as somebody who's got a spinal or hip bone mineral density of within 1 standard deviation of the young adult. Osteopenia, often referred to as bone mass, will be between -1 and 2.5. Osteoporosis being less than -2.5. And severe is when you've got the less than 2.5, but has presence of 1 or more fragility fractures. It's something that needs to be taken seriously. There is a bit of an issue with this definition because it's relying on you having a single measurement at one point, which often lacks sensitivity. And as I've mentioned before, we know very well that not all patients that fracture are fracturing and have a bone density that's in the osteoporotic range. Often it is in the osteopenic range. And the definition and the data and the cutoff were all based on healthy Caucasian postmenopausal women. Can these be used appropriately in African patients? We're still not sure because we don't have the data. And what's important to note as well, which is something that often gives people a false sense of comfort, is when you think a patient's got osteoporosis, they've had a fracture, and then you send them for a bone density scan and it comes back with high heat rings. That does not necessarily translate to an increase in bone strength, because there's often confounders, often in the older patients where they've got osteoarthritis as well, which can often give you false readings as well. And then
Sorry about that, everyone. There we go.
So the other issue with this definition is that I think it's still trying to break up a little bit.
Is it not taking like that?
Yeah.
Okay.
It's stuck.
Good. There we go.
So the other issue is that this definition is not applicable to premenopausal women and men under the age of 50. In this case, the Z scores, not T scores, are preferred. And the Z scores of -2 or lower is defined as below for the expected range in that age. And these should be population-specific scores. So who must we think about screening for osteoporosis? Or women over the age of 65, men over the age of 70. Something that we tend to ignore that happens a lot. I don't think any patient that walks through any hospital walks out without an X-ray, but often the bones are ignored in the X-ray and we worry about the other things that are there, and sometimes often not there in a normal chest X-ray, that we don't look and pick up the evidence of low bone mass, and obviously the presence of one or more risk factors. What risk factors must we consider is obviously major modifiable risk factors, inadequate nutritional absorption, lack of physical activity, high for risk, weight loss, cigarette smoking, alcohol consumption, air pollution, and stress. What other major non-modifiable risk factors? Obviously, your history of falls, your age, nothing you can do about that. Gender, Caucasian ethnic background, prior fracture, and obviously reproductive factors, your family history of osteoporosis. And obviously one that tends to come up quite a lot is the secondary causes, chronic use of certain drugs, which we'll discuss a bit more, hypogonadism, hyperparathyroidism, chronic liver disease, inflammatory diseases, renal diseases, cardiovascular, diabetes, which is coming up quite a lot, and dementia as well. Some of the drugs that are commonly play a big role in impacting bone negatively is androgen deprivation therapies used prostate CA. And these often result in a deterioration of about 2 to 5% above your normal expected deterioration for age, and often results in almost a 30 to 50% increased risk of fractures. So ideally, all those patients actually should be screened for osteoporosis. Even patients who are on aromatase inhibitors, we know very well glucocorticoids are a big issue, as well as selective serotonin uptake inhibitors, and the TZDs that often people think have been phased out of clinical practice, but they are still available and still in use as well. And as Judy had mentioned earlier, that it's quite important to try and not interrupt this normal trajectory of your bone, because you puberty and reaching a peak bone mass is very important between the ages of 20 and 30s, and we know from then on you would stabilize until around the perimenopausal period, where your bone density will then deteriorate. Which this normal trajectory of bone creates quite a bit of problem, especially with a lot of things that have come into picture, especially in terms of therapies used in adolescence, what drugs we use in that pubertal period, a very also quite typical issue in patients who are transitioning transgender patients and use of hormonal therapy, in terms of are we not preventing them from achieving their peak bone mass and predominantly increasing their risk later on of reaching menopause. The diagnosis is mainly based on the measurement of a BMD in that appropriate ranges. Also, what's often ignored, which is what we need to educate a lot of clinicians on, is also the diagnosis can be made purely on the evidence of a fragility fracture, that they don't necessarily require bone mineral density. And we know very well bone mineral density, the gold standard is a DEXA scan, but there are other techniques that are available. A lot of them predominantly used for research purposes, not so much for clinical, which have been very helpful in understanding bone a bit better and looking at outcomes, and especially bone quantity as well. But our problem is that we have an issue with DEXA access in Africa and Middle East. I mean, in our hospital, which is one of the largest hospitals of Sub-Saharan Africa, we only have one DEXA machine. So it's quite a big issue that we don't have enough DEXA machine, which is why in our situation, we need to keep in mind the fact that in a patient that's got a low impact fracture, don't wait for the bone density to happen for you to make the diagnosis. It is important for that to happen, especially for monitoring of therapy, but it's not the only thing requirement, especially in an attempt to try and reduce mortality and reduce the risk of a subsequent fracture as well. Something that has come into the picture, which is often helpful in those patients where you think that the bone density is a borderline, they've got risk factors, is a fracture risk assessment tool, which is quite an easily accessible tool that's available on the web. It gives you a 10-year probability of a fragility fractures based on several common clinical risk factors. This is available in most countries. We are fortunate in South Africa that we've recently had the FREX available specifically for our population. So what this tool tells you is basically requires you to enter the patient's details, and you enter their age, and obviously some of the risk factors, and it will give you an estimated calculation of what your risk of having a fracture is. And this calculation tool can actually be done without entering the bone mineral density. So you don't necessarily need the bone mineral density to do the calculation. Of interest to me is that there is a small box there at the bottom that tells us individuals with fracture risk assessed in 1st of June 2011. So obviously ours was only, this is when the tool was established. Ours obviously is very recent, so last year. You will see only 1,046 patients have been assessed. And I will show you in comparison to the UK one, look how many patients have been assessed on the FRAX tool. as well. It's quite a lot. So I think we are underutilizing the tool in terms of trying to assist us in deciding on whether to treat patients or not. And then in terms of laboratory testing, obviously there's some minimum, this is the basics. Obviously, other tests and a bit more might be required depending on your patient's clinical history. There's a calcium, magnesium phosphate, alkaline phosphatase, parathyroid levels, the creatinine, and the vitamin D. So the least the patient has to have in terms of assessment and prior to treatment is this laboratory test. In terms of deciding which patients to treat, patients that we need to decide on which to treat are patients with a prior fragility of fractures, irrespective of what their bone mineral density is. And obviously patients that got a bone mineral density of less than 2.5 at the hip spine, and a BMD that's between 1 and 2.5 under special circumstances. And this obviously you will consider depending on risk factors, the FRAX score, and whether if it's drug related, whether there's ongoing treatment and the risk of fracture as well. This is from our own treatment guidelines in South Africa from the National Osteoporosis Foundation, in terms of just assisting us in terms of how to proceed and how to think about therapy. That in women and men with risk factors or prior osteoporotic fractures, if they do have, then you consider treatment. If they don't have any osteoporotic fractures, you then will measure your bone mineral density. Depending on your T-score, you will then consider treatment. If they don't meet criteria for treatment, then you would more institute lifestyle measures. And obviously something that's important to keep in mind in all of this is to consider the utility of the fracture. The other tool that I found useful is this one from the Endocrine Society guidelines from 2019 in terms of helping us decide. Why I put this slide specifically is that it also highlights on what patients, what treatment you would consider. In that, obviously, when you've got your patients with or postmenopausal, you would institute lifestyle and nutritional changes, and then you will do your 10-year fracture risk as well. And then you'll decide on whether you use anti-resorptives or you use your anabolics. One, your bisphosphonate, which can be oral or intravenous. You would reassess your fracture risk in 3 to 5 years, meaning once you start therapy, you only do your bone density at that point. Generally, the treatment will be 5 years for oral, 3 years for IV. But obviously, if a patient is high risk or continues to lose bone or sustains a fracture on treatment, you can extend the duration of therapy. And then obviously, denosumab, which is probably available in the country as well, is available as an option for treatment. And you will see this being mentioned quite a lot, as it is one of the safest to use in patients with renal failure. But of concern when it comes to denosumab is the risk of vertebral fracture that is rapidly increased post stopping the drug, which these patients would then require another agent to help stabilize the bone post the denosumab use. But long term, so far, it's been safe to use. And then anabolics are also available that they can be considered, generally not as first line therapy. Forteo is available in South Africa that you can use for 2 years, obviously with other adjunct therapy. With romosozumab not available. And obviously in other patients that are more younger and around the perimenopausal time, use of hormonal therapy is also a consideration and is quite important. And then just lastly, in terms of treatment, something I just wanted to highlight on is what drugs are actually available with your bisphosphonates and what impact they have on bone. So in terms of the one that we've all been very familiar to using is zoledronic acid, which is a once yearly intravenous infusion, which has been shown to have good data in terms of fracture reduction in the vertebral, hip, and non-vertebral fractures. What you would note, which is something I want to bring attention to, is ibandronate. You would be aware that actually that the Department of Health is actually trying to move away from the use of zoledronic acid towards ibandronate intravenous, which is quite a big concern because it requires infusions every 3 months. And then there's no data to suggest that it has significant fracture reduction on hip and non-vertebral. And then obviously I've mentioned with the denosumab, also very good subcutaneous every 6 months with not excreted through the kidney. And then your hormonal therapy and parathyroid agonists also available for use in osteoporosis. And that I will end there. But I think just one more thing I just want to highlight that's important is that let's not ignore bones. Bones are important, not just for women only, but especially in women. And something like an index presentation of a low impact fracture is an important event. And let's not mix the opportunity to intervene at that point and initiate treatment and assess patients appropriately, which is why there's quite a big movement in trying to establish fracture liaison services where you would identify patients. So basically an intentional fracture identification system where you find the patients and then you treat them appropriately and then worry about the bone density and everything else later, as long as the initial screening process is done again. Thank you.